Is there, like, can you do that in a mouse or a guinea pig? Is there an experimental model? You just go straight to humans?
Yeah, I think it, there's been intratracheal installation of these drugs, which may not really recapitulate the way it's self-administered. So to my knowledge, there isn't sort of an actuation way of doing it with this animal models. Perhaps the closest is the intratracheal administration of the drug.
So I wonder about the ethical ramifications of having an anti-transmission drug that probably has side effects but doesn't benefit the patient primarily. Is there a precedent for drugs like that?
I think it's a great question. We don't know yet whether this is going to have an effect on the patient's disease burden or not. We're primarily interested in studying transmission, given sort of the burden of disease explainable by transmission. Depending on the results of our exploratory endpoint, it may be a place to build to look at whether there's an effect of inhaled antibiotic therapy to affect the disease burden itself.
Right. It seems hard to imagine that it would decrease infectability without having some benefit to the patient. If it's decreasing viable bacterial burden, it's likely to have some benefit, and certainly inhaled colistin is used routinely for highly resistant gram-negative lung infections for the purpose of benefiting the patient, not for transmissibility purposes. Even though it's local, it certainly can have marked pneumonia benefit.
Right. Just two comments on that. I think we do hope and potentially will see an effect on the disease burden with the surrogate measure of sputum culture conversion. But I think some of that is really an opportunity to think about drug development and design. So part of where this drug is landing in the patients, with this particle size, much of it may be able to go into the distal airways and into the alveoli. There haven't been studies to really look at the distribution of this dry powder formulation within the patient's lung. Is most of it just ending up in the trachea? Is it going out to the periphery and being absorbed there? So those are important questions to ask, and I think if we get a signal through this study, it may be an opportunity to look at, what's the distribution? Is it going to affect disease in the peripheral sites of the lung and not just centrally?
We have time for one more question.
Are you checking cholesterol levels in the blood of patients?
So we are not, at this point, doing pharmacokinetic analyses in the blood, but certainly an important component to do to understand some of the mechanisms and efficacy of this.
Serum creatinine, can we take?
Yeah, we do follow that.
Are you doing any PK analyses from respiratory secretions?
Not at this point, but we've discussed that and hope to be able to do that, perhaps with some additional
It'd
funding.
be nice to know what kind of drug levels you're achieving and the distribution.
Right.